Welcome to Redefining Global Health in the 21st Century. It's a new book that has been written by Reid and Eric Goosby, and I'm delighted that they're joining me this afternoon. Good afternoon, gentlemen.
Good afternoon, Ben.
So, today we're talking about where the rubber hits the road. We're going to follow the money because, let's face it, that's where the abstract becomes real. And in the chapter on finance, Mike started with a fascinating case story about what happened in Zambia, something that, as we'll find out, matters very, very much to him. In early 2025, we all know the decision that came out of Washington, where decisions were made about cuts to PEPFAR, the US major global investment in HIV. The decision reached a community center in Kitwe, Zambia, where a pastor watched his congregation shrink by almost half overnight. It reached a 10-year-old girl who opened the tin where her HIV medication was kept and she found it empty. And it reached the market vendor who had started stretching 1 month of pills across 3. None of them had any say in the decision that upended their lives. So we've looked at governance, we've looked at potential opportunities to grow the AIDS epidemic, the AIDS response, but we're at a point where we can do nothing without the money. And that's the conversation today. Mike, if I could start with you first. What happened in Zambia was very personally important to you. And we've done a podcast on A Shot in the Arm talking about your decisions that resulted from that. But can you explain to us why that Zambia story is so important in kicking off the conversation about finance?
So this story from Zambia took place a number of months before I decided to resign, and really is and full disclosure here, it's a story that is captured in the public press by a reporter from the NPR, which I adapted for the book, but really tells paints the picture of what happened when the U.S. government decided to pause its foreign assistance programming to Zambia back in January of 2025, and what happened overnight was that these programs shut down. Programs that were delivering life-saving treatment to vulnerable populations across Zambia. Whether there was some artistic license in the original narrative, who knows? What is clear is that many people quickly found themselves without healthcare, without antiretrovirals, unable to access the services that they had previously had, and many programs were unable to sort of function without ongoing support from U.S. government, and it was a really useful illustration of how parts of the Zambian healthcare system had become so dependent on the U.S. government that a single shock from resulting from that pause in funding had numerous bad knock-on consequences for the healthcare system, and we use this just as an example of how Zambia, like many other countries, had become dependent on U.S. funding for its HIV program. The chapter really is really focused on how do we move to a post-aid global health space where most countries are not dependent on donor financing to sustain their health programming. And we discuss a number of different strategies or solutions that might help us get to a point where many countries, many low and middle income countries that are currently dependent on donor financing might be able to run effective health programs without reliance on external funding. But we also talk about the reality that there are going to be some countries, some low-income countries, and some populations in countries that will probably continue to need support from external sources, even in the long term. And what should that look like? So those are some of the things the chapter addresses.
So Zambia, 84% of its HIV funding came from the United States, and in so many provinces, US staff or US funded staff were the only clinical or health support that these people with HIV and people at risk of HIV in the country had. This is going to be inevitably an infuriating conversation, and I don't want to lose that. But will then turn in a very sort of cold-hearted way into what the future holds, because the rah-rah call for countries can fund this themselves. They don't need donors, they need to manage it themselves. That clearly isn't the case for countries like Zambia and Malawi, for example. And when the decision came through from Washington to suspend PEPFAR, what did folk like you do? How did you respond? Did you say to the leaders, "Look, this is madness," or was this such shock that you just had to continue as best you could?
It's a great question. In in the couple of weeks that followed, there was a furious amount of activity behind the scenes to try and persuade the political decision makers of the impending consequences of those decisions. And a number of briefs were quickly drafted that outlined the epidemiological impact of pausing programs, the diplomatic impact of pausing programs, the economic impact of pausing programs, to try and communicate to the political leadership that this was a disastrous decision. Regardless of whether it was disastrous or not, the administration was legally entitled to undertake that pause and strategically reevaluate their global health portfolio. So they weren't beholden to Congress for that decision. But on the ground, I think the response was quite different. There was tremendous amount of uncertainty from colleagues in the Ministry of Health in Zambia about whether there would ever be a resumption of US funding. And in the meantime, implementing partners were terrified that they weren't going to get funded for work that they were going to do. There was also quite a lot of innovation. Folks on the ground figured out ways of trying to sustain programming, enabling people to access care even without resources. There's a tremendous amount of personal resilience stories. I think we've included some in here of people who work without pay, who chose to show up even though they weren't getting paid. Some sort of programmatic shifts happened so that people had to come less frequently and could access their meds without coming to clinic as often as possible. Government pivoted to using paper-based charting tools because they couldn't access the computer records that were behind locked doors. So in the short term, a lot of resilience. But I think all of this speaks to the fact that we were in that position because the whole HIV response had become so reliant on US funding. And that was a problem that actually preceded Trump coming back to power. And I think there is a lot that could have been done in the years, preceding that could have helped incent partner governments to invest more, that could have included explicit expectations that there were co-investment strategies required. And we can talk about what some of those things could have looked like. Unfortunately, they didn't happen. And we ended up in a place where countries like Zambia, and as you alluded to, maybe they couldn't have afforded to, foot the bill anyway, but countries like Zambia were left hanging with no resources and a huge amount of disease to address.
Eric, this must have been heartbreaking for you, given all the work you had done as the PEPFAR coordinator in the early 2010s to mobilize and build up sustainability in countries like Zambia?
Indeed, it was. It was really met with mostly disbelief initially that they couldn't be thinking about really doing that. If we didn't have the privilege of having Mike in kind of the core of the dialogue as the scientific director, was in the middle of it and became the clinical consult internally because there was not a duplication of his training, background, and experience available to them. So he became kind of the clinical consultant internally, which I believe they trusted.
You're kind, but
Well,
I don't think I have as much influence as
okay,
you
yeah.
might state. I certainly was an advocate for change, but look, there are a lot of people on the inside.
Yeah.
Yeah,
From my
I certainly
perspective,
I was beating a drum for sure.
that's-
But there were others too. Yeah, but you're
no, they were for sure.
yeah.
I think for me, Mike, you brought a credibility that I don't see duplicated in the arena there as admirable as all of them are, and where your experience was real, and if I were listening to it, it would be hard to dismiss because it wasn't based in a hypothetical. It was based in a real understanding of how the disease moves through a person and through a population. At any rate, I would say that I was distraught for really, it's the first time I think I've been clinically depressed in terms of what happened. COVID kind of put me into a strange mood, but it was potentiated with this as I didn't recognize the immobility initially as depression, but it clearly retrospectively was. And this is a guy who's never really been in a depressed anything, wasn't part of my experience. So I really was affected by it. Took it as it couldn't be. Took things like with the National Academy of Science Medicine that they were seriously going to be the conduit through which a real discussion was planted and grew. And it's as if it didn't happen. And the attacks on Harvard became more of a real pedestal of opposition, as ephemeral as that was, to the pushback. But there was no place to put your angst. And the administration, were skillful at becoming unavailable. They weren't talking to anybody internally or externally, and they weren't talking to the people in the field at all. They weren't talking to the academic funded people by PEPFAR or Global Fund in the communities that they had access to. Nothing was tapped. It was an abandonment of everything. A strange thing to do for someone who's responsible and serious about what they're doing.
Yeah.
So there was disbelief, and this couldn't be what's happening, and it's just a matter of it'll emerge. There'll be a face to talk to here shortly. And it never really emerged, from my perspective. The hopefulness that was out there grew and paled, just waned from neglect.
Yeah.
It wasn't that, some other conversation picked up. The other disappointment was the funded foundation world and high worth individual world postured a lot, but didn't really convene a process. They convened discussions that were truncated, did not continue. They had no intention of thinking. The biggest thing I saw evolving was a growing awareness that they couldn't take on what the government of the United States had been doing. And to think of us as that is something we need to really downplay in all of our discussions. They overemphasized their inability to engage. And as a result, I think, eliminated themselves from a lot of what would have been, I think, helpful, strategic, small little sprinkling, peppering of funding to convene that critical discussion, get the people who needed to be aware of what's going on to think through what to do. That wasn't happening. And usually in my world, it did happen. Those convenings were done by somebody or a group of people or entities because they were needed, as people saw that, so they were facilitated. That didn't happen with this. It was an abandonment of the discussion, the process, for fear of telling the truth to those convened that would be unacceptable. With the fear was that what they really were intending to do was so unacceptable, they knew it, is my take on it.
I was horrified and I still am, that many, particularly in the Washington arena, working in this field, are still looking at trying to find pragmatic solutions. And, all credit to them for trying to do that. But I don't think there are. And that is why this conversation about making sure this never happens again is so key. And one question to get us into that: do you think that donor dependency in Zambia, as an example, was the inevitable price of this extraordinary success story that had been PEPFAR? Or was it a design choice that could have been made differently? And you were sort of referring to that in the years prior to the Trump administration. But could we have built the foundations of this differently in any way?
I mean, my personal feeling, and it's easy with the benefit of hindsight to sort of infer whatever I like, right? But I think it potentially was a design choice. There was this decision to scale HIV programming to respond to the HIV epidemic that was best served by a donor-funded vertical program in countries. And there was an abundance of resources from Congress. And as long as there was an abundance of resources, the imperative to incent partner governments to invest in their HIV response was probably diminished. But if we'd have gone a little bit slower and done the HIV response with a mind to long-term domestic financial investment, I think we may have been able to avoid this. I don't want to be conclusive there. I use may because, as you alluded to, I mean, countries like Zambia have substantial amounts of sovereign debt. I mean, 50% of Zambia's current financial revenue from taxation goes to paying off its debt. So the expectation that it has unlimited discretionary funds to invest in health is not there. And then, as you've alluded to in earlier podcasts, ministers of health are sort of at the bottom of the kind of cabinet pecking order. When they ask the funds from Treasury, and that's true in Zambia as anywhere else. But could donors, could the Global Fund and the US have done better to incentivize more co-investment over the last 2 decades of the HIV response? Yes. Could that have been a model for crowding in more resources for health more generally? Yes. Could we have leaned into new innovative ways of encouraging private sector investment? Maybe. I don't think there is truly any sort of innovative financing out there that works to sort of, there's no egg that lays, no goose that lays golden eggs.
Yeah.
But I think there are things that could have been done that weren't done. And maybe we'll learn this lesson now moving forward.
I mean, one of the things, so yes, but one of the things that needs to be added to this is the history of colonialization. And take Haiti as an example, which you did in the book, that, there is still such an a reparation that needs to be paid to France in this instance for the price of independence. And you can see that right across the continent of Africa, where the mercantile elements of colonialization have remained, even if the political ones haven't. And as you say, how on earth can you expect countries to increase their domestic spending on health, and in this case HIV, if so much of their money is going back to the countries that they are reliant on aid for?
Right. And we just joke about this in brief, but there are many scholars, particularly anti-colonial thinkers, who have articulated very well how many countries, particularly in sub-Saharan Africa, but elsewhere as well, have been disproportionately weighed down by debt and and the negative consequences of years of coloniality that have made it hard for them to take off from a health point of view right from the get-go. And so the notion that like the US or European countries are doing good by investing in their health programs right now should also be held in tension with the reality that the wealth of places like the US and the UK was predicated on coloniality right from the get-go. I mean, I think there's some data that the UK has taken more than $17 trillion of wealth from India over the course of its colonial rule. And so the fact that India has taken so much longer to sort of achieve health, and certainly still doesn't succeed, is very much a consequence of decisions that were made 100 years ago by British rulers. Yeah.
So when we talk about countries being prepared, being better prepared to manage this epidemic, the countries we really ought to be talking about are the ones, the colonizers, and the ones who continued to expect payment back on loans, on reparation for different features of the end of the political colonization. And that's probably more important than pointing a finger at these poorer countries and saying you need to get your house in order. So we can spend more time talking about the history in the book. It does talk about how we got into this situation. But I think a more interesting and upbeat conversation is, okay, we are where we are. Where do we need to be? What do we have to do to make sure we don't let this happen again? And I don't know, at the 38,000 foot, I mean, Eric, perhaps I could start with you, and then with Mike. What do we have to do? What would effective financial solidarity with countries look like?
Well, I think that the idea that countries are going to be able to suddenly figure out how to do this themselves and suddenly find that pot of money or resource that they just had overlooked is really unrealistic to think that someone hasn't tried and exhausted all those avenues. It's not that we've forgotten how to do something. It's that the country itself has decided to not say and prioritize this as something they want for their population and are willing to pay for it with the resources they have control of. That simple decision hasn't been made in most of the countries we're talking about. And in the big countries we're talking about, both the developing and developed, that same tension is still there often. The United States is a perfect example of that. The UK is truly an exception on the planet in their decision to move forward with, national health insurance. We haven't made that decision in the United States, and it hampers everything we do and precludes our ability to save gobs of resources by telling the city of Oakland, San Francisco, that we are going to look at your population as a population, look at the needs of that population as one, and not 500,000 people broken up into different insurance company conduits of resources for reimbursement that fragments everything, makes the response to COVID a joke locally. And I mean it. When that is totally understood, people will cringe with how closely we came to a non-response because of the unwillingness of insurance companies to work together to have a common testing strategy. We're not going to put anything in. Kaiser, United Health, all the Sutter Health, all the big insurance companies. The University of California, San Francisco's first reaction was, wait a minute, we're not going to pay for that. That's not part of what we have in your buying healthcare from us. We don't promise you we're going to do prevention. That was their first argument. We don't do prevention. We're here for the treatment part of it. And kept that argument for about 3 months. And then they realized, really dumb, and went to, well, we'll do in parking lots will do common testing efforts. That was the concession. But my point is that that need for attribution drives so many, precludes so many opportunities to converge resources and be additive instead of, uh, iterative, that it's tragic. But the will isn't there, really, internationally or domestically. And I think those conversations, to my knowledge, have not matured enough or even happened in most cases to go start that, march to that pathway, going down that pathway. So to me, that needs to be convened. Deciding on what we are building is the first part of that.
Mhm.
Are we going to have a delivery system or not?
Maybe I can add. I mean, I think as we think about the role of high income investments in donor programs, I have a couple of reflections, but I think there's three separate related questions that we want to ask. One is how should donor investments in health programs be invested to avoid the kind of dependency we saw in Zambia moving forward? Second is, if we're moving away from investing in health programs through, through donor initiated interventions, are there other ways of funding programs? And third, how can countries do a better job of mobilizing their own resources to help fund their health programs? And those three questions are sort of related but different.
Mm.
And I think the first of those three questions, which is what are key functions of donor funding moving forward, there's lots of different ways of answering it, but from a disease agnostic point of view, I think there are like two or three things that are worth highlighting. Donor investments are really effective at closing equity gaps that governments may not have the same political will to close. Something we talked about in our last podcast. But in a country that has a less than hospitable political environment for key populations like MSM, donors can play a really important role in providing services to those populations that wouldn't otherwise be provided. And that's really important. That equity function, I think, is absolutely essential and should be a key proponent or component of the US government's HIV response. Unfortunately, isn't right now, but should be. The second key function of donor-funded programs, though, I think is investing in elements of health programs that have a global good.
Yes.
Some diseases are very transmissible across borders. Some are vaccine preventable diseases. And if you can scale up vaccine access programs at the point where the diseases are most prevalent, then you prevent them coming back to other countries. That's a really valuable reason for investing in programs overseas. And then a third reason for continuing to invest in donor programs is underwriting the transition of those programs from being donor dependent to country fully financed. And there are lots of things that donors like US government and Global Fund can do to sort of facilitate that transition, whether it's through co-investment incentives or helping their public financial management systems to work more efficiently, whether it's through supporting new models of generating tax revenue. All of those things can be done with donor financing that ultimately lead to a bigger pie of money being available. Yeah.
And that requires donor countries sort of accepting the concept of dropping the debt. The idea that countries pay you a certain amount of money for debt that they have incurred from you. And that money is greater than the money that you then invest in countries. There has to be an honesty about that. And thinking about donor honesty, if they're being really honest about the strategic self-interest, does that make the system more accountable, or does it, or is it just naming what's going to happen and what is already happening and it won't change?
I'll just react to it. It's very hard to expect a kind of population who's responsible for the resources that have been invested in your treatment capability in country X in Washington or in London to be accountable to the outcome that that money buys. They're not. They never will be. No one even tries to connect the dots. So the decisions get made in the following year by a group of people who have no awareness of the outcomes or nor are asked to investigate them, tie them to it. And we've had integrity with the decision makers within programs that have kept that reasonably on point. But it's easy for that to drift. And as soon as you abandon it without that kind of dedicated group of program, analysis on top of it, you lose it. And donors that do that, and there are many countries in Europe that was the way they did their bilateral programs. It's a joke what happened to their resources. To that point, the PEPFAR investment was always more rigorous and more impactful because of the oversight that PEPFAR can deliver compared to the Global Fund, too, as another big program. And I saw that play out early on in the way the programs were implemented. We had a lot of room for, the areas of duplication and parallel systems was, when I started, the norm, not the exception. Countries had a different procurement delivery system for every funding line they had different sites for every funding line they had, different pharmacies for every funding line they had. So we were able to harmonize that and save hundreds of millions of dollars, and we're able to take a 1.7 million cadre of people on antiretrovirals up to the 5 million.
Yeah.
That was the first big jump.
Yeah.
Maybe just a sort of additional reflections. I didn't quite track the question, but now Eric's response has helped me kind of inform an additional insight, which is what twofold. One is that to its detriment, PEPFAR up until this point never required partner governments to co-invest as an expectation on donor financing. Global Fund has always done that. It hasn't necessarily enforced its co-financing requirement, but that may not be a bad thing. We do it in other areas of our life. We ask for a matching investment for when we give to charity, sometimes things like that, right? And that's the kind of model that maybe could help partner governments to have been thinking about investing in health programs earlier than they have done. And then the other thing that through PEPFAR we could have done a better job on and haven't done is giving money directly to partner governments through what's often called government to government financing mechanisms. And ironically, this new administration, the Trump administration, are leaning into that. Eric can speak to this in a much more detail than I can, but historically, over the sort of trajectory of the PEPFAR response, there was a kind of ambivalence to using G2G mechanisms out of concern that it could lead to corruption or diversion of funding. And I think there's some examples of where that happened. And historically, the US government has been sort of risk averse in terms of giving funds that could be, diverted in that sense. What has resulted, though, is often a sort of a bureaucratic public health response where the US government ends up funding an agency, CDC or USAID, which then funds an implementing partner to deliver programs that are parallel with the partner government's own healthcare system.
Yes.
So there's lots of indirect inefficiencies in the system, and it's a system that exists parallel to the government's own system. And this current administration, I think their vision was, well, if we do away with all of that duplicative parallel implementing partner infrastructure and we give funding directly to partner governments, then maybe we can find efficiencies in the response that have been missing up until now. That may not be such a bad thing if done well. Obviously, there's still a concern that funds will get diverted or be used inefficiently by partner governments. But those two things, lack of co-investment, under use of G2G mechanisms earlier in the HIV response, maybe things that we'll look back on and think, oh, geez, we could have done that better if we'd have thought of those things earlier.
There's another way, or an additional way of looking at it. For those countries that service significant debts in poorer countries, you could argue that a proportion of that debt recovery remains in the country to be used for health services, and then I'm just feeling that the emphasis has been on partly shaming and blaming countries for the risk of corruption, and there are examples of that being done. But the fundamental problem is that they don't have the resources to invest. And while we can talk about how we reframe donor funding and look at co-investment opportunities, perhaps the biggest co-investment comes from the donor country itself in removing elements of its debt.
Yeah, I mean, I think debt to health swaps are a thing. Global Fund sort of
Gordon Brown was
Yeah.
passionate about that.
and within Global Fund, I think there are lots of examples where they're being used. Whether they're being used on the scale that they could be used to mobilize resources for health. So, what a debt to health swap involves, I'm sure somebody will correct me on this, but a high income sovereign nation forgives the debt to a recipient country, contingent on that country investing all of the repayment of their debt into health. Sounds great in practice. I don't think that the full impact of debt to health swaps has been realized. But sure, I think it's one example of something that could be used a lot more. And when we talk about climate, I think there's an opportunity for thinking more about, climate resilient funds in that same bucket of innovative ways of funding climate resilience. Yeah.
Yes. And of course, another way of looking at it is through mechanisms like Gavi and the Global Fund, which were supposedly to pool investments, and then countries went through a process of applying on the basis of strong evidence-based programs. And there's part of that model that works, but there's still an element of the board in Geneva, even if it's made up of different sectors, that board in Geneva making the decision. And is there a way in which the Gavi and the Global Fund models could be modernized to make it easier for countries to generate income through these mechanisms, but also build structures that allow them to do the right thing with the right kind of review to minimize corruption? Is there an evolution of these institutions that might make sense?
I mean, I think if I understand part of your preamble correctly, Ben, one issue is who determines eligibility for donor financing, and that is, I agree, that is somewhat arbitrary. I think Global Fund and Gavi do have eligibility criteria, but it's beholden to sort of shifting pot of resources, right? But I think greater transparency around eligibility would be really, really helpful, particularly ensuring that eligibility is sort of means tested and not being defined by some political agenda. That's true for multilateral donor financing initiatives. I think it's harder for me to imagine that bilateral donor financing programs like PEPFAR will ever want to be beholden to some concrete eligibility criteria, because ultimately the US government chooses who it invests its health its donor resources in based off of political reasons.
Mm-hmm.
Yeah.
But if we were able, Eric, to in our vision of the future, encouraging the downplay of bilateral funding, which is decreasing anyway, and moving more funding to a Gavi global fund model, and that when there are big initiatives like PEPFAR that come into play, that they are automatically drawn to the global fund, the global administration of this. Is that a positive development, or is the global fund and Gavi too Geneva bureaucratic to be able to manage that kind of mass funding, that mass intervention?
Well, I would think that to think that the correct response is when there's a problem, mount a separate and individual rallying to put the resources, knowledge, and capabilities together to do it, to mount a response, is very inefficient. You're going to do a lot of duplication of that capability in human resources. It's not necessarily a problem. We've done it that way because of the non-belief that WHO or the UN system could carry the need. And that was the real impetus for it. It wasn't that we thought it was the way to go. It was really that we're afraid that if we gave it to a multilateral of one type or another, it wouldn't get done. And that's an impression that is widely felt, maybe not fairly, but is widely felt and needs to be addressed. Things like the United States pulling out has not helped that impression. But if the world decided that this was our attempt to make resources available to countries that don't have that resource, and we're all going to match it with bilateral examples of capability infusion, so technical assistance type interventions coming too, but from a bilateral conduit, you could make some real sense out of this and distribute the resource need across a broad, points of activity that could go from government to academic to private sector, and all accountable to a political system that gets somebody voted in or out. That needs to be the system we build, and none of this other stuff. We need to keep it locally defined and accountable. Those have to run hand to hand.
Do you know, I have a funny story about the UN and the Global Fund. Back in 2001, I think it was, on one of the side meetings of the high-level forum on HIV and AIDS that took place there, was a meeting of UN agencies. And I was there as a note taker for the deputy director of UNAIDS. And it was all about what to do with the Global Fund. And right around the table, you can look up the co-sponsors of UNAIDS, and I shan't name and shame them, but everyone was saying, well, we should have the Global Fund. The Global Fund should sit with us. No, it shouldn't. It should sit with us. And the deputy executive director, who was a very brash New Yorker, said, look, guys, I just got to tell you, this shit is done. Quote, the ship has sailed as a global fund that is nothing to do with us. We've got to work out how we work with it. And I remember one head of agency saying, well, this is completely unacceptable. I don't accept that decision.
That worked.
But it does speak to, we're constantly trying to create something that's better than the last. And in the case of the multilaterals, it takes us to a conversation we had in the previous episode about what we want the WHO to do. But I love the idea of us pooling resources in the way that you described, a sort of, don't quote me, but a global fund 2.0.
I guess just to push back on that, maybe I'm the pessimist in the room. I feel like the will for a new or even a reimagined multilateral funding mechanism for global health is minimal. And the more important conversation is, how do we get countries to a post-aid era where they're no longer reliant on any donor financing? And what should donor financing be investing in now so that we realize that post-aid era for more countries as soon as possible? And I think there are some interventions that can ensure that success happens, in terms of ensuring that countries are engaged in how aid is invested. As I said before, embedding transition and sustainability into the planning process, ensuring that any donor investment is predicated on outcomes-based programming rather than just compliance to some
Whatever.
reputation. Yeah. But ultimately, I think the bigger question that we should be asking is really like, how do we get to the place where countries are no longer requiring aid, right? And as I said right at the beginning, there are going to be some countries that unfortunately are so poor that their health systems are not viable without donor investment. But for everybody else, there's a bunch of other solutions that we should be thinking about.
Yeah, and there are countries, and you could see it in Kenya, you could see it in South Africa, that after the shock were able to mobilize national resources. I think getting to a place where, and it particularly applies to Africa, where Africa is not reliant on donor funding, that's a multi-year task. And I guess what happens in the meantime, and what I'm sensing from both of you is this idea that we need to move away from donor funding hegemony, that they call the shots, because even with Gavi and Global Fund, there's still too much of that. They'd kill me for saying that, but I think that's the reality. So how do we get there? What do we do to keep the donor funding, but not let the donors have the ownership of it in the way they have done, that has been damaging to the evolution of Pan-African health responsibility?
Well, I think there are things that donor funds can be invested in that enable greater country ownership, right? And that's where perhaps resources should be prioritized. I've alluded to some of these already, but strategic investment, technical assistance for public financial management systems, so that countries can grow their own pot of resources, so that they can use their own resources better, are likely to be helpful. I'll just take a little tangent here and say that this current administration, the US administration, has so badly shot itself in the foot, because they dismantled USAID, which was the primary agency for supporting those kinds of strategic investments in partner governments. And all of their expertise around public financial management was let go. So this administration's own capacity to support partner governments to invest more in their healthcare system has gone.
Yes.
It was such a stupid decision. But I think nonetheless, investing in PFM is, and supporting
PFM.
public financial management systems and supporting greater domestic resource mobilization, those are value-added investments that will enable countries to achieve sustainable health programs sooner. So that's the kind of thing where I think there could be value.
So there's a track here of helping countries get to a point where they manage and fund their healthcare.
Yeah, and there's a fairly robust evidence base from scholarship looking at Global Fund and Gavi and even the Gates-funded Abraham program in India that sort of helps us think through what a successful transition of programming look like, so that countries can assume both the financial oversight and the program quality of historically donor-funded programs. And that's what we should be looking to. The U.S. administration has moved to these bilateral MOUs to sort of facilitate ongoing PEPFAR programs moving forward, and those MOUs include some of the principles that I think are necessary to facilitate transition.
Yeah.
But they're being done on an unrealistically rapid timeline with a really small sort of technical oversight from the US government, that it's hard for me to imagine that they will be successful in enabling country ownership and sustainable programming.
Another track might be looking at alternative funders like sovereign wealth funds. Remember the business? We thought briefly that the business sector could help there. I mean, Eric, how realistic is it, do you think, that we can find new pots of money to be brought into this?
Yeah, I think unless we figure out a way for the new pot of money to have a profit motor as part of it, finding a way to tag on to for-profit investments. I would actually say, I think most of the time spent on putting a plan together with a partner country as a bilateral investor is a waste of time, largely. It was much more efficient and effective to just start implementing the program that you get an agreement on you want to build, and build it. Engage each problem as they present themselves to you, and you solve them together. That's going to build a more resilient, responsive, and effective program than anything we've done with this crazy bilateral, and that's going to require government-to-government funding kind of at the core of it. And take the leap. Get the bad guys who corrupt with the money stealing. Find them and get them. But you need to make that commitment to the country and the gesture and abandon that you demonstrate to the country that you trust them on a very fundamental level with your money. That is the beginning of the relationship. I just do that.
That is the key. It's a question of trust. And for so many of us, we're living in the 1960s, 1970s, where countries can't be trusted. And there are all sorts of reasons that, going back, that we believe they can't be trusted. And incidentally, these things come through an organization I've been involved in looking at its future. I've heard things say like, well, of course, Africans can't manage money.
It perpetuates their colonial relationship.
That's right.
That belief.
Yeah.
And I need you to continue to believe that so I can continue to take it north.
Maybe I can go back to the sovereign wealth fund question, because I think probably I'm the one that inserted that into the book, so I should speak to it.
It was a new idea to me.
But
I liked it though.
So right now, sovereign wealth funds manage more than $13 trillion globally. So there are a number of countries that use sovereign wealth funds, whether those be earnings from windfall taxes on extractive industries, or are capitalized through Federal Reserve excesses, or it depends on the country. Norway, for example, has one of the biggest sovereign wealth funds from its hydrocarbon industry, and has used it very effectively to invest in their health programs. I had two thoughts around sovereign wealth funds. One is that even low and middle income countries could conceivably set up sovereign wealth funds. Could Zambia take some of the windfall taxes from its rare mineral mines and generate revenue from the wealth fund there to invest in health. Maybe. But then I think the other idea, and this is not my idea, it's you can find it on the White House's own website. Trump has outlined an idea for a US sovereign wealth fund, which again, presumably is
Mary, Mother of God.
where windfall taxes on extractive industries or other resources, and and who knows what they'll invest it on. But it's conceivable the US could have a sovereign wealth fund that like outsizes every other sovereign wealth fund, generating a huge amount of revenue. And I wrote about this on my Substack a couple of weeks ago. Like even a small fraction of that going into global health could have a massive impact, and would not hurt any taxpayer's pocket.
But Mike, do you really think a sovereign wealth fund under Donald Trump is a good idea? Because based on his behavior, we know where that money goes.
Well, I think there'd have to be sort of, congressionally approved accountability mechanisms, of course, because we don't want it to go into anybody's pockets. And I'm not naive to the reality that I don't think it will go in global health, but it's conceivable that a sovereign wealth fund for the US could be invested into health. And that feels like a no-brainer for me. That would be a great investment for an area of US society that is massively underinvested in.
Only, again, if we can somehow create an environment where countries are calling the shots and people providing funding from whatever source are saying, this is not a responsibility that you, the donor, that you, the donee, the recipient have. It's a responsibility that we have to support your establishment of national funds. Well, I guess we're coming up to the end of this podcast, and I'm struck by, we know what we don't want, but we've got to do a lot of work on thinking about what we do want. And there are thinkers, there are institutions around the world that are thinking about bits and pieces of this, but it's got to be pulled together, and it's going to be a multi-year effort. And in the meantime, we have to make sure that people don't die of HIV, malaria, and TB, amongst others. So what would be your parting shot, your parting words of wisdom, Mike, in terms of how we reach the future?
Yeah, I mean, I think we've really just scratched the surface, and there is a caveat in the beginning of this chapter. Neither Eric or I are health economists or finance,
and nor me.
It's a little bit outside of our wheelhouse, but I think there are other tools at our disposal. Development finance institutions like the DFC, the Development Finance Corporation in the US. These are entities that use investment, private sector investment, to advance development goals. Like, there's potentially an expanded role for those moving forward that we should be excited about. I think public development banks, similarly, like, can we reimagine how they could play an expanded role without crippling governments with debt? And then the final thing, and we didn't talk about it at all, is thinking with governments about how they can mobilize more domestic resources. A lot of interest in sin tax, taxing things like alcohol and tobacco, which has sort of a double whammy. By sort of reducing consumption of unhealthy goods, but also investing into health. That's one example. I think there are lots of other ways that governments can and should be thinking about how they grow their own investment in health. And that has to be the central thrust of how we address global health issues moving forward, domestic resources.
I think longer term, you're right. And I think many countries are thinking that already as a result of the shock to the system that came from the whatever happened to PEPFAR. That sounds like a good name for a Hallmark movie, doesn't it? But it's what we do in the meantime, and how we move all these tracks together. And I don't know, Eric, as the arch diplomat, what advice would you give us about how we get to where we need to be, as Mike has articulated it.
Yeah. I think we really need to define the destination that we've talked about over the last few convenings. And that is healthcare the priority for this population or not? Once that's decided, it opens up a logical progression to finding resources for it that come out of the tax base. Because accessing the tax base is really what we need to do for something like healthcare. It's not going to come from small commitments. It's going to be a total commitment. And we haven't gotten our population to agree to do that in the United States or globally, both. That conversation needs to happen and happen in such a way that it includes the people who can pay for it, which includes the donors and the non-donors together in a process that probably some sociologist or psychologist has figured out a way to move a really divergent conversation toward a conclusion. We need that kind of help, but we need to convene it. We are trying to fly without a destination, and it's bullshit. How many years do we want to do that? We've done it for 30.
Yeah.
How many years do we feel this is the right way to do it? And the Einstein idea of you keep doing the same thing over and over again and expect a different outcome really comes to mind with this.
Yeah.
And we're smart enough people to figure this out. That's what's so frustrating about it to me, is that these aren't questions. The answers for these we've largely figured out. We haven't put them into a system where people can access them. It is just so tragic. But connecting those dots requires quite a conversation on the front end that I haven't seen occur anywhere. What did the UK do? They had World War II to say, we were bombed so much, we deserve a national health service. I mean, but we should look at what happened there.
Well, and we had a fantastic politician
And you did.
in Anurin Bevan,
Yes.
who
That's right.
who pushed it. My hero in health. Yeah. There we are. There's a bit
But there's
of
a something there anyway.
the National Health Service.
They came through in the end.
Yeah.
But I think you're right, Eric. Unless we figure this out, then we are on the brink of the Scene.
Yes.
You know, like with the degradation
Yes.
of programs that have been successful.
Yep.
And this will be the end of the golden era of
Yeah.
global
The
health. So
tragedy of it.
we do need to figure this out. But there are lots of solutions. You know, the combination of which I think may be the destination.
You know, Mike, you make me think of just the civilizations that have come and gone, where you see a level of craftsmanship early on in the bas reliefs that, what Göbekli Tepe in Turkey. This is a 12,600-year-old religious, they think, site that they have found. I'll tell you about it later, but the bottom line is the early artwork in the piece on the stonework that they did showed great mastery of the skill. And then as the eons went forward, they lost that skill. The things that they did later was nowhere near the level of craftsmanship of what the original contribution was. And just as you have put this together, we are doing that. We're allowing things we did know how to do or figured out in the past at some point, letting it just drift into the air. Anyway, so.
Well, I think that is our call to action.
Yes, there's
To make this happen. I think there's some work for us to do outside these podcasts, but we have got to get this convening done. I would say that's an uber priority. Well, look, with that, thank you both very much for giving us the time to talk through the chapter on finance in Redefining Global Health in the 21st century. Mike, as we round out, there are a couple of people from UCSF that we would like to acknowledge.
Special thanks to May Forster and Tatum Sanderbeck for facilitating this podcast series and their help with the book and the comms related to it.
Thanking them very much. Thanking also our director and producer, Eric Aspera from A Shot in the Arm Media. And finally, a big thanks to you for watching and listening. You can find us wherever you download your podcasts and visit our YouTube channel where you can see all of the episodes as they come out of Redefining Global Health for the 21st Century. So it just remains for me to thank you and to wish you a great and safe week. Thanks so much.
Thanks, Ben.
Thanks, Ben.